Hello, everyone, and thank you for joining us for today's presentation on the use of psilocybin to treat nicotine dependence. What is known? A review of the literature. This is a fairly new and exciting domain of research, and there is a lot of hype about it. And I think it's important to try and maintain a good balance between the promise of psychedelics and some of its limitations. As you'll hear, there are a lot of good results associated with these compounds, but we must also remember that we're still in the early stages, and many of the studies are quite small with heavy inclusion criteria. And that should give us pause as we think about the broader benefits to the public and what those benefits may look like as the field progresses. I will be trying to maintain and convey this sense of balance throughout today's presentation. My name is Jim Pavlik, and I'm the Senior Program and Policy Analyst at the Behavioral Health and Wellness Program in the Department of Psychiatry here at the University of Colorado Anschutz Medical Campus. I've been with BHWP since the fall of 2013, and I have been a nationally certified tobacco treatment specialist since 2018. I'm also a certified psychedelic coach, and in a matter of a couple of weeks, I will also be a licensed psychedelic facilitator here in the state of Colorado. A course of action that I embarked upon in late 2023 based largely off my curiosity surrounding the studies by Roland Griffiths and Matt Johnson, particularly the latter, because as you will see, although the study has significant limitations, the findings were quite astounding. I also want to acknowledge that I am not a neuroscientist, and the information I share today is not centered on that aspect of this topic, although it is a significant feature of today's talk. I'm coming at this as a certified nicotine cessation specialist. That is, I hope to provide a crosswalk from the lab to the curious clinician, whether that person is a licensed facilitator or someone who is potentially thinking about referring a patient to one. What are the things that I would need to know in order to properly inform both my decision and also how best to educate and prepare clients that are interested in pursuing psilocybin as their pathway to cessation? And one final point, I'm not recommending psilocybin as a treatment for nicotine dependence. I'm not in a position to do that. For now, it remains a curiosity. It is not an FDA recommended treatment. My point here is to merely provide information on what is known about that pathway for now, so that both clinicians and patients can consider that possibility with open eyes. That being said, today's presentation is not a medical or mental health screener, nor is it a playbook for the practicing administrator. This is merely to highlight critical pieces of how and why psychedelics may be used to treat nicotine dependence. Other than those things, I have no other conflicts of interest to disclose to you. Today's learning objectives are relatively straightforward. I hope that you will understand the emerging theoretical frameworks that may explain how psilocybin facilitates lasting behavior change, including addiction recovery. Together, we will explore the broader psychedelic landscape through an examination of how psilocybin and other psychedelics are used to treat various conditions associated with substance use and substance use itself. And we'll review the current clinical and research evidence that supports psilocybin as a treatment for nicotine dependence, including major studies and their outcomes. Tobacco use remains one of the leading causes of preventable death worldwide, contributing to a range of chronic diseases, including cancer, heart disease, and stroke. In fact, smoking causes 6 of America's top 10 killers and is associated with the other 4. Despite widespread awareness of its health risks, quitting nicotine is notoriously difficult. Current treatments, such as nicotine replacement therapy, varenicline and bupropion, and behavioral counseling can be helpful, but success rates are modest. Most people attempting to quit relapse within the first few weeks or months, and many require multiple attempts before achieving long-term abstinence. While some individuals do succeed with existing treatments, others find them ineffective, inaccessible, or unsustainable. This persistent gap highlights the urgent need for new, more effective cessation strategies. Innovative approaches that target both the physiological dependence and the psychological drivers of tobacco use may offer some hope. In recent years, new approaches to smoking cessation have emerged, each offering unique mechanisms of action. Cytosine, a plant-derived compound, works similarly to varenicline by targeting nicotinic acetylcholine receptors, helping reduce withdrawal and cravings, representing a conventional pharmacological strategy. Transcranial magnetic stimulation is a non-invasive neuromodulation technique that uses magnetic pulses to stimulate brain regions associated with cravings and self-control, such as the dorsolateral prefrontal cortex. Early studies suggest it may be helpful to disrupt habitual smoking patterns. GLP-1 receptor agonists, originally developed for diabetes and obesity, are being investigated for their potential to reduce nicotine cravings and reward sensitivity through action on the brain's reward circuits. Finally, psilocybin, a classic psychedelic, is gaining attention for its potential to promote lasting behavioral change across several domains, but particularly with substance use disorders. As we get started, it's a good idea to know what we're talking about when we say psychedelics. Psychedelics are a class of substances that alter perception, mood, and cognition, often producing experiences of expanded awareness or deeply meaningful insights. They do not typically cause physical dependence and are generally non-toxic at common doses. While many substances may be called psychedelic, researchers often categorize them based on how they work in the brain. Classic psychedelics are traditionally broken down into two categories, the phenethylamines and the tryptamines, with LSD, technically an ergoline, included as a tryptamine. These two or three categories include compounds like mescaline, psilocybin, DMT, and LSD, among other less common ones. These substances primarily act on the serotonin 2A receptor and are known for their ability to reliably produce altered states of consciousness, including vivid imagery, ego dissolution, and profound emotional experiences. Outside of this group are what are called atypical or non-classic psychedelics, which may have similar subjective effects, that is, they are perceived to be similar in the mind of the patient, but they work through different pathways. These include MDMA, which acts on serotonin and dopamine systems, and ketamine, a dissociative anesthetic that acts on NMDA receptors. A slightly different taxonomy based on the drug's core ring structure simply uses two groups for the classic psychedelics, the indoleamines, which formally and usefully includes LSD with DMT and psilocybin, and the phenylethylamines, which is essentially congruent with the previous phenethylamine group. Psilocybin, the focus of this presentation, is a classic psychedelic showing strong potential for treating addiction. Once administered, psychedelics reliably cause a range of common effects. Subjective effects are heavily dependent on personal characteristics of the patient and therefore vary in terms of which effects may manifest and in their relative intensity. Among these common effects are alterations in perception. Psychedelics can alter the perception of shape, size, and color and create the illusion of movement. Vivid imagery is common, even with the eyes closed, ranging from geometric patterns to representational images. Other senses may also be altered, and synesthesia can occur. Synesthesia is where stimulation of one sense activates another sense, so people can maybe see or feel music, for example. Psychedelics reliably produce changes in thought and mood. The psychological content and emotional tone of the experience are unpredictable and can change rapidly. Feelings of bliss, joy, peace, anxiety, depersonalization, derealization, and paranoia can all occur. Strong cathartic emotional experiences are also common, often related to past or current life experiences. Particularly at higher doses, mystical type experiences are frequent occurrence, and we'll talk more about that in just a few slides. Psychedelics lead to an altered state of consciousness. The altered state involves an acute modular disintegration of the default mode network, followed by a reintegration of this network with normal functioning, which may lead to improved psychological flexibility and cognition. There is an increase in the complexity, unpredictability, or entropy of brain activity, which correlates with the intensity of subjective effects. Some of that will be illuminated throughout today's presentation. Psychedelics can induce ego dissolution, which is the separation of boundaries between the world and oneself, or one's sense of oneself. This experience is thought to facilitate personal insight through introspection by removing mental hurdles and relaxing psychological or ego-based resistance, helping to dissolve rigid patterns of thinking. Experiences with psychedelics are often described as highly personally meaningful and spiritually significant, with participants often rating them among the most meaningful experiences of their lives. Participants frequently report gaining valuable insights into self-identity, personal reasons for behaviors such as smoking, and deeper truths. These insights can lead to a decreased desire for problematic behaviors. These feelings can persist beyond the acute drug effects and diminish the relative importance of addictive behaviors. There are two main approaches to using psychedelic compounds in a therapeutic setting: the psycholytic and the psychedelic models. The psycholytic model, which originated in Europe and is therefore sometimes referred to as the European model, involves multiple lower doses of psychedelics administered alongside ongoing psychotherapy. Rather than aiming for a single transformative experience, this approach uses psychedelics to gradually reduce psychological defenses, enhance emotional openness, and support deeper therapeutic work over time. In contrast, the psychedelic model, sometimes called the American model, was popularized in early LSD studies and emphasizes a high dose delivered in 1 to 3 sessions intended to produce a powerful, often life-changing experience. This model aims to trigger sudden insight, emotional breakthrough, and lasting behavior change. Both of these models shaped the early landscape of psychedelic therapy and continue to inform modern clinical research. Modern trials often draw from each, combining structured preparation and integration with carefully guided psychedelic sessions. The studies at the center of today's presentation are more akin to the psychedelic model because it uses 1 to 3 high doses of psilocybin. At the same time, it also utilizes several sessions of cognitive behavioral therapy. In fact, all of the studies highlighted today use a combination of both psychedelics and therapy together, and I don't think I can understate the importance of that. As I'll point out in just a minute, earlier studies using psychedelics alone often found immediate large benefits, but these benefits often failed to last. Even at the time, researchers considered that ongoing therapy may both enhance and prolong the short-term benefits of these drugs. Modern research has borne out this early speculation in the power of augmenting psychedelics with therapy. Before the Controlled Substances Act of 1970 effectively halted psychedelic research, there was a surge of scientific interest in using psychedelics, particularly LSD, to treat addiction, especially alcoholism. Between the 1950s and early 1970s, researchers published hundreds of studies, including clinical trials, case series, and observational reports. While methodologies varied, and many studies lacked modern controls, a consistent theme emerged. A single high-dose psychedelic session conducted in a therapeutic setting could lead to significant reductions in alcohol use. A 2012 meta-analysis by Krebs and Johansson revisited 6 randomized controlled trials from this era, assessing LSD's efficacy in treating alcoholism. The analysis, encompassing 536 participants, found that a single dose of LSD administered with various AUD treatment programs was associated with a significant reduction in alcohol use. Specifically, the odds of improvement in alcohol use were nearly doubled compared to control groups, with negligible between-trial heterogeneity. However, the benefits observed were primarily short-term. While improvements were noted up to 6 months post-treatment, the effects were not maintained at 12 months. And the authors highlighted the need for further research, suggesting that repeated doses of LSD, combined with contemporary evidence-based alcohol relapse prevention treatments, might yield more sustained results. They also recommended investigating shorter-acting psychedelics, such as psilocybin, for their potential in treating alcohol use disorder. The mid-20th century experiments with LSD for AUD set the stage for modern studies on psilocybin and tobacco. But before jumping immediately to how it works, I'll first present some evidence that psilocybin works in general and work backward from there. Recent research has explored the use of psilocybin combined with psychotherapy as a treatment for a range of substance use disorders. While still in early stages, findings across multiple small clinical trials and pilot studies have been encouraging. Psychedelics in general, and psilocybin in particular, have been investigated as a potential aid in treating tobacco, alcohol, opioid, and cocaine use disorders, and several more studies are currently underway. Across the completed studies, participants often report reduced cravings, greater insights into the roots of their addiction, increased motivation to change, and a sense of personal meaning or renewal, all of which may support long-term recovery. A consistent pattern has emerged. A small number of carefully guided psilocybin sessions embedded in a therapeutic framework can produce sustained reductions in substance use for some individuals. While effect sizes vary, outcomes often exceed those seen with conventional treatments, at least in the short term. Like LSD in the middle of the last century, modern trials have shown that psilocybin-assisted therapy may be effective in treating alcohol use disorder, a condition often resistant to traditional treatments. Early pilot studies, such as the 2015 open-label trial by Bogenschutz and colleagues, found that participants receiving psilocybin sessions alongside psychotherapy experienced significant reductions in drinking and cravings. Building on this, a 2022 randomized controlled trial led by the same team demonstrated that psilocybin combined with motivational enhancement therapy produced a 14% greater reduction in heavy drinking days over 32 weeks compared to placebo. While these results are encouraging, larger studies are ongoing to confirm long-term benefits and establish best practices for integrating psilocybin into alcohol treatment programs. Nevertheless, the success seen here in pilot and RCT form serve as adequate analogies to what we will review momentarily with psilocybin and with psilocybin and tobacco, adding some confidence that what was witnessed there is not the result of chance, but a genuine effect of the compound. In attempting to determine why or how psilocybin works to treat substance use disorders and why its effect seems to be so consistent across drugs and treatment designs, one major area of uncertainty that we have to address is our general understanding of the etiology of substance use disorders themselves. Now, obviously, this is a topic far too great to handle with a lot of nuance in the time granted to us today, but as we will see, we must have some general appreciation of the etiology of SUDs if there's to be any understanding at all of how psychedelics treat SUD in general and how psilocybin treats tobacco use or nicotine dependence specifically. And there are several competing models of SUD. I've listed here what I think are the 9 most prominent, along with an extremely brief description of each. I can make these slides available if people want to read it, because we don't even have time to review these models at this level of detail, but here they are. But I would say this, there is a general consensus that we can distill from these 9 models. One element of this consensus is that there are empirically identifiable genetic predispositions. Now, obviously, we can't put all of our eggs into the genetics basket. Many people with supposed predispositions do not acquire an SUD, and many without predispositions do. Still, the effect seems fairly large across major SUD diagnoses. Another area of consensus is recognizing the role of early childhood, and especially the role of various kinds of abuse, neglect, and other adverse childhood experiences called ACEs as correlates of SUD, perhaps mediated by ACE's effect on the development of anxiety, depression, emotional dysregulation, and other mental illnesses, or the various criteria thereof. But again, it's important to acknowledge that not everyone with one of these precursors acquires an SUD, and many without them do. All either agree or do not offer commentary on the roles of exposure, access, and the general sociocultural acceptability of drug use. But like genetic predisposition, that such systemic or structural factors exert influence is undeniable, even if the magnitude of their effect is debated across models. Finally, all agree that drug use itself causes measurable changes to specific areas of the brain, alters functions of the brain, and that these changes have reinforcing effects that prolong drug use and act to prevent recovery. Furthermore, much of this reinforcement is by means of causing or exacerbating many of the factors that act as precursors for themselves or for others. In short, psychedelic therapies may be engaging across multiple domains listed in this integrative model outlined. Better treatment of antecedent and consequent mental health conditions like depression may serve to simultaneously cause remission and prevent relapse. At the pharmacological level, activation of the serotonin system and modulating the dopamine reward pathway may help heal areas of the brain damaged by drug use, damage that, if left unattended, may prolong use and discourage recovery. Similarly, at the cognitive level, resetting critical neurological systems may help reframe priorities and or work to empower individuals. Finally, the mystical experience may provide new insights, establish new priorities, and assist patients in aligning their actions with deeply held values that are granted new salience through the psychedelic experience. And perhaps all these work together to help reframe and make new narratives around past traumas and other early developmental influences. And so we'll look at some of these in a little bit more detail. Psychedelics may help treat substance use disorders not only by targeting addiction directly, but also by addressing underlying or precursor conditions that often contribute to substance use. These conditions include depression, post-traumatic stress disorder, and anxiety, among others. These and other conditions can increase vulnerability to addiction or complicate recovery. By alleviating symptoms of these mental health challenges, psychedelics may reduce the emotional distress and cravings that drive substance use. Beyond these, psychedelics have also been studied for their potential to improve obsessive compulsive disorder, eating disorders, and end-of-life psychological distress, all of which highlights their broad therapeutic effects. Addressing these root causes can create a stronger foundation for lasting recovery from addiction. For example, some individuals, it seems, acquire tobacco use disorder as a result of self-medicating their depression with nicotine. However, a different individual may not have had depression. Nevertheless, this second individual may subsequently develop depression due to their tobacco use, which then encourages further use of nicotine while independently making relapse more likely if the person should attempt to quit. This recognition of the bidirectional relationship between SUD and many of its common effects is instrumental in some currently existing evidence-based SUD treatment modalities, like dialectical behavior therapy, or DBT, which treats emotional dysregulation as a therapeutic target. In DBT, emotional dysregulation is first addressed as a means of harm reduction, helping the client to prevent new crises that may disrupt treatment and/or act as a trigger for drug use. It then continues to develop emotional regularity as a means of preventing relapse, recognizing that emotional dysregulation may have been a major precursor that led to the initial SUD diagnosis and thus would lead to relapse if left unaddressed. In fact, this connection between treating depression and as a consequence, getting tobacco use disorder remission was at one time a leading theory as to how bupropion works. And it was this hypothesis that led researchers to look into SSRIs as a potential nicotine cessation medication. In the case of bupropion, it works equally well as a cessation medication, regardless if the patient qualifies for a diagnosis of depression, which is maybe slight evidence contrary to this hypothesis. But with SSRIs, a modest and short-lived cessation benefit was observed, but only in patients with depression. Now, and this acts as slight evidence in favor of this precursor hypothesis, evidence that might be stronger if SSRIs had a stronger, more universally positive effect on depression. Now, psilocybin has shown strong potential as a treatment for depression, including cases that have not responded to conventional therapies. In both open label and randomized controlled trials, psilocybin-assisted therapy has led to rapid and sustained reductions in depressive symptoms, often after just 1 or 2 sessions. Unlike traditional antidepressants, which are typically taken daily and may take weeks to show effects, psilocybin works through a single high-dose experience supported by psychotherapy. Participants often report increased emotional clarity, a sense of connectedness, and the ability to view their problems from new perspectives. Neuroimaging studies suggest that psilocybin may reset dysfunctional brain network activity, particularly in the default mode network mentioned previously, which is often overactive in depression. While the exact mechanisms are still being studied, these changes are thought to support psychological flexibility and emotional processing. Importantly, psilocybin is not merely masking symptoms. It may be helping individuals engage more deeply with the root causes of their suffering. These findings are driving large-scale trials to further assess its safety and effectiveness. Atypical psychedelics have already demonstrated efficacy in treating PTSD, a condition often resistant to standard therapies. While the FDA eventually chose not to approve MDMA for this purpose based on significant issues in the clinical trial data, that same body of evidence did lead a Dutch advisory panel to recommend its adoption, and it still enjoys innovations passport status in the UK and breakthrough status here in the US, with official approval still pending on the completion of an additional phase 3 trial. Classic psychedelics are emerging as a potential treatment for PTSD as well. Most studies using either classic psychedelics predate the DSM-3 diagnostic category now known as PTSD. However, studies done in the 80s in the Netherlands on what was then called concentration camp syndrome and studies in the 60s on traumatized patients both showed promise. More recent efforts using ayahuasca, which contains the classic psychedelic DMT, have anecdotal support, and confirmatory studies are currently underway. Psilocybin has several proposed mechanisms of action that, if confirmed, would likely address significant components of PTSD, and anecdotally, those who have used psilocybin do report significant breakthroughs associated with past traumas. The salient pharmacological and neurologic mechanisms are detailed quite well in a paper in the citations here called Maudlin et al. 2025. So you can find that citations at the end of the presentation today, or I can just provide it upon request. Psilocybin has also shown promise in reducing anxiety, particularly in individuals facing life-threatening illnesses or chronic psychological distress. Clinical trials involving patients with advanced cancer have demonstrated substantial and lasting reductions in anxiety following 1 or 2 guided psilocybin sessions. Participants often report experiencing a sense of peace, acceptance, and a reorientation of priorities, changes that persist long after the acute effects of the drug have worn off. These experiences are frequently described as among the most meaningful of a person's life, which may contribute to lasting improvements in mood and anxiety symptoms. Psilocybin appears to reduce activity in brain regions associated with rumination and fear, including the amygdala, which may help explain its calming and perspective shifting effects. Beyond existential anxiety, emerging studies are also exploring psilocybin's potential for treating generalized anxiety disorder and social anxiety, especially, again, when paired with supportive psychotherapy. While more research is needed, current findings suggest psilocybin may offer a novel pathway for those who have not found relief through traditional anti-anxiety treatments. In addition to treating nicotine dependence by treating precursor conditions like depression, there are other potential mechanisms at work. The first of these to consider is that activating the 5-HT2A, that is the serotonin 2A receptor itself, and the downstream effects of that activation may be therapeutic in and of itself. Psilocybin is converted in the body to psilocin, which acts primarily as an agonist at the 5-HT2A serotonin receptors, especially in the cortex. Activation of 5-HT2A is a commonality shared by classic psychedelics. It is, in fact, the characteristic that defines the class. Although, as this table shows, different classic psychedelics activate different sets of serotonin receptors. But 2A is the one they have in common. And activation of these receptors is thought to increase cognitive flexibility, reduce habitual behavior, and enhance emotional insight, all of which can help individuals break compulsive substance use patterns. And they are the neurological correlates of many of the treatment effects of the conditions just described. Although psilocybin doesn't act directly on dopamine receptors like stimulants or nicotine, it indirectly modulates dopamine pathways, particularly in the mesolimbic reward system. And this could help normalize the dysregulated reward processing that is seen in addiction. By inducing emotionally meaningful experiences, psilocybin may help individuals recontextualize triggers and cues associated with nicotine use. This could support a process known as memory reconsolidation, weakening the emotional grip of nicotine-related memories. The default mode network is a brain network involved in self-referential thinking and rumination, both of which are overactive in addiction. Psilocybin appears to decrease DMN activity during acute effects and may reset its function longer term, disrupting rigid thought loops that maintain addiction. Preclinical studies suggest that psilocybin may promote neuroplasticity, including the growth of new dendritic spines and synaptic connections. And this may support long-term behavioral change and learning new, healthier patterns. One of the most intriguing and most consistently reported mechanisms behind psilocybin's therapeutic effects is the spiritual or mystical experience that it can induce. These experiences are characterized by feelings of unity, transcendence of time and space, deep emotional insight, and a sense of sacredness or interconnectedness. The idea that such experiences can promote healing dates back over a century. William James, often called the founder of modern psychology or the father of modern psychology, in the Varieties of Religious Experience, 1902, proposed that mystical states could lead to enduring psychological and behavioral change. In the 1960s, Walter Pahnke conducted the Good Friday experiment, showing that psilocybin could reliably induce mystical experiences in religious settings. And building on this, Roland Griffiths and colleagues at Johns Hopkins demonstrated in modern clinical trials that the intensity of the mystical experience correlates strongly with positive health outcomes, a finding that was also found in the tobacco studies that we'll show in a second. In addiction treatment, these experiences may help individuals break free from rigid patterns of thought, reconnect with deeply held values, and experience a sense of renewal or forgiveness. Many participants report that these sessions instill a profound motivation to live differently and often free from addiction. Spirituality and faith have long been recognized as influential factors in addiction recovery. The 12-step programs, such as Alcoholics Anonymous, emphasize a spiritual framework, encouraging individuals to seek support from a higher power. And this approach has been associated with improved recovery outcomes. Empirical research supports the beneficial role of spirituality in substance treatment. A systematic review found that higher levels of religious faith and spirituality were associated with more optimistic life orientation, greater perceived social support, higher resilience to stress, and lower levels of anxiety among individuals recovering from substance use disorders. Furthermore, studies have indicated that spiritual practices can enhance self-efficacy in resisting substance use. For instance, a survey of participants in a faith-based 12-step program revealed that increased spirituality was linked to greater confidence in abstaining from substance use. These findings suggest that integrating spiritual components into addiction treatment may provide individuals with additional resources for coping, meaning-making, and community support, all of which are vital for sustained recovery. So, with all of that as background, let's look at the research that supports the use of psychedelics, particularly psilocybin, as a treatment for nicotine dependence. And so first we'll explore a few studies that have looked at psychedelic use in naturalistic settings, that is, not within a therapeutic container. A large-scale 2022 study led by researchers at Harvard explored the relationship between classic psychedelics and nicotine dependence using data from over 214,000 adults in the National Survey on Drug Use and Health. The research examined whether lifetime use of psychedelics like psilocybin, mescaline, peyote, and LSD was associated with a current nicotine dependence. They found that people who had used psilocybin were significantly less likely to meet criteria for nicotine dependence, and that mescaline and peyote use were also linked to lower scores on several measures of nicotine addiction, including tolerance, compulsive smoking, and prioritizing smoking over other activities. Interestingly, LSD use was associated with increased odds of nicotine dependence, highlighting differences either between the substances themselves or the differential ways that those are used in naturalistic settings. In either case, these findings suggest that certain classic psychedelics, particularly psilocybin and mescaline-containing compounds, may have protective or beneficial associations with tobacco use. In an online survey investigating naturalistic psychedelic use and its association with tobacco smoking cessation, researchers collected data from 358 individuals between September 2013 and May 2014. The anonymous cross-sectional survey targeted individuals who reported quitting or reducing smoking after a psychedelic experience outside a laboratory setting. Participants who typically smoked 14 cigarettes daily for 8 years and had 5 prior quit attempts completed a 40-minute questionnaire. Results showed that 38% of participants achieved continuous smoking cessation after their psychedelic experience, with 74% of these maintaining that abstinence for over 2 years. Another 28% reported a sustained reduction in smoking, with 62% maintaining this reduction for over 2 years. Notably, participants across all groups experienced less severe withdrawal symptoms compared to previous quit attempts. Quote, changing life priorities or values was the most frequently cited mechanism for their success, and those who successfully quit or reduced smoking reported their psychedelic experience as more personally meaningful and spiritually significant than those who relapsed. In a similar but more recent study exploring the impact of naturalistic psychedelic experiences on smoking, researchers conducted an online survey from November of 2021 to April of 2022. The methodology involved surveying 173 French individuals who had smoked previously and undergone a psychedelic experience in a non-clinical setting. The survey gathered data on demographics, characteristics of their psychedelic experience, tobacco addiction levels, and psychological flexibility. Researchers found a significant decrease in the average number of cigarettes smoked daily and the proportion of individuals with high tobacco dependency following a psychedelic experience. Participants who successfully reduced or quit smoking reported more intense mystical experiences during their psychedelic session and showed an increase in psychological flexibility after their experience. These findings suggest that personal motives for the psychedelic experience, the intensity of the mystical experience, and increased psychological flexibility are all positively associated with smoking cessation or reduction. In a cross-sectional study examining the impact of ayahuasca on ayahuasca use on substance use disorders, researchers assessed 1,947 adult members of a Brazilian religious community, the União de Vegetal, that ritually uses ayahuasca. The methodology involves evaluating alcohol and tobacco use disorders through questionnaires based on World Health Organization and Substance Abuse and Mental Health Services Administration criteria, comparing current and lifetime prevalence rates within the UDV community to general Brazilian norms. While lifetime prevalence of both AUD and TUD within the UDV sample was similar to or even higher than Brazilian norms, the current, that is past 12-month prevalence of both disorders was significantly lower for the church members. Specifically, tobacco use disorder prevalence rate was only 3.9%, and that's less than half of the national prevalence rate of 9%. Regression analyses further indicated that regular attendance at ayahuasca ceremonies and years of UDV membership both significantly contributed to the reduction of alcohol and tobacco use disorders. This suggests a strong association between religious ayahuasca use and decreased problematic substance consumption. While the findings so far described are, in my opinion, compelling, these studies are based on observational cross-sectional data, meaning that they can show associations, but not the cause and effect relationships. Because they rely on self-reported lifetime psychedelic use and recent nicotine dependence, it's sometimes unclear whether the psychedelic use occurred before or after the onset of addiction. Other unmeasured factors like personality traits, mental health, or social environment may also help explain some of those associations. Additionally, the studies didn't measure the frequency, the context, or the dosage of the psychedelic use, which are likely important in therapeutic outcomes. Clinical trials are needed to determine whether psilocybin can directly support nicotine recovery. So in the next few slides, I'll be sharing a closer look at the Johns Hopkins pilot study led by Matthew W. Johnson. But before going into that, it's worth understanding the general setup for the therapeutic application of psilocybin in the psychedelic model. In general, these applications are divided into three components: preparation, administration, and integration. Jumping to the middle, by administration, I mean the administration of the drug. Depending on the drug and the dose, the administration session can last between a few and several hours. For psilocybin, at the psychedelic dose of approximately 2 to 3 grams of fruiting bodies, or roughly 25 to 35 milligrams of psilocybin, that session will last about 5 to 6 hours. Plus a couple of hours for paperwork and to ensure safety prior to discharge. Preparation includes going over and signing all the regular healthcare paperwork you might expect: patient bills of rights, privacy, confidentiality, medical and mental screening, disclaimers and liability, basic safety precautions and processes, and post-discharge transportation arrangements. But it also means preparing them for the psychedelic experience. The psychedelic experience is unique, and it's characterized by a difficulty in even explaining it to others. Its ineffability. The strangeness and an associated disorientation can be a cause of anxiety and fear. And it can also be fun and entertaining, which might be distracting the patient from their therapeutic endeavor. It can create a sense of vulnerability in some clients. So it's important for the facilitator to use this opportunity to demonstrate their competence and trustworthiness. The therapeutic alliance is just as critical here, if not more so, than it is in a traditional psychotherapeutic setting. Most individuals will require at least 1, often 2, and frequently more preparation sessions, both to ensure their comfort, but also to optimize the therapeutic outcome. The psychedelic experience is filled with thoughts and ideas and concepts, some of which are new and some of which have just gained a new powerful salience. And the lessons one may learn from it are not always straightforward, nor are they obviously immediately actionable. And so the process of integration is there to, well, help them integrate these new insights into their daily life. Now, in general, and governed by regulations here in Colorado, the administration session itself is to be non-directive. That is, the facilitator is not a guide who is trying to explain the session to the client while it is happening, assisting them in forming lessons from the images as they are witnessed, or attempting to focus their attention on this or that issue. The facilitator is present simply to guarantee the client's physical safety and to make them feel comfortable when they can. And if anxieties or fears arise, to reassure them that they're safe. Which is to say that the psychosocial interventions and the application of any specific therapeutic modality typically occurs during the preparation and integration phases. Along the bottom of this slide is the workflow for the Johns Hopkins study we're about to review. This included 4 preparation sessions. the first psychedelic session and its accompanying integration session the following week, followed by the second psychedelic session and its accompanying integration session. This was followed by 4 CBT support sessions. There was an optional third psychedelic session and its integration session, and this was followed by 4 CBT follow-ups, and then the final meeting. And as you can see, this intervention was quite intensive for both patients and practitioners. One more thing before looking at the Johns Hopkins study, and that is setting proper expectations regarding its findings. What does cessation look like in a non-psychedelic context? In 2021, Hartman Boyce and team at the Cochrane Library combined 26 systematic reviews into one enormous systematic review looking at the behavioral health interventions for smoking cessation. This culminated in 312 studies with a total of 845 study arms. I went through each of those 845 study arms and selected all that looked like they contained the following characteristics. They contained some medication. It contains something that was referred to as coaching, counseling, or therapy. It contains somewhere between 4 and 19 sessions. It wasn't measuring telephonic, web, or app-based interventions. The behavioral intervention was done individually, not in a group format. It was delivered live. If the health of the study group was noted, I eliminated studies on unhealthy or low health individuals because the Johns Hopkins study specifically screened for health and excluded those in poorer health. In short, I included every study arm that, in its broad strokes, resembled something, but resembled what was done in the Johns Hopkins study. Then I limited that list down to the 20 studies with the best cessation rates and looked at them further to make sure they actually matched the criteria. Here I eliminated a few more because the studies were done through apps, online, or over the phone. And that left the 6 studies you see on this slide. And here you can see that when we have 3, 6, and 12-month data, the biggest drop-off is in the first 3 months. I would add to that typically about half of that drop-off occurs in the first 30 days. Then you can see that there is less relapse between 3 and 6 months, and even less between 6 and 12 months. Across these 6 studies, total cessation at 12 months was between 22.6 and 35%, for an average of 27.2. And that is more or less exactly what we say when we're asked what the cessation rates are in evidence-based gold standard care right now. We normally say somewhere between 25 and 30% success with pharmacotherapy and counseling. And as a complete aside, I will note that the 2 varenicline studies here were the 2 highest performers, which is aligned with the current push to have varenicline considered first-line treatment. Okay, so on to the Johns Hopkins study. The study and its results have been extensively detailed. The original study has had 3 papers published on it, and the team also did a long-term follow-up. These papers are pictured here, and citations appear at the end of the presentation. This study, led by Matthew Johnson, was, in its broadest description, a very traditional tobacco cessation intervention, except that it also included psilocybin. Participants received several preparation sessions, which included, among other things, the use of tobacco cessation psychoeducation in the form of manualized cognitive behavioral therapy exercises. Then they received what is considered a moderate dose of psilocybin, 20 milligrams per kilogram of body weight. Participants were also provided the opportunity for a second or even third dose of psilocybin at future visits if they either did not achieve abstinence with the first dose or if they needed additional support to maintain their abstinence. Second and third sessions were supposed to be at a higher dose, 30 milligrams per 70 kilograms of body weight, but participants were allowed to repeat the 20 milligram dose if they wanted. The dose range here, 20 to 30 milligrams per 70 kilograms, was determined by a few previous studies, also at Johns Hopkins, and these studies determined that this was the range that was the one that provided the best opportunity to occasion a mystical experience without incurring additional risk of adverse events. Let me say that in a slightly different way. Above this amount, the chance of the participant having a mystical experience doesn't actually go up very much. The curve starts to flatten out. But the chances of the participant having an adverse event, normally high levels of anxiety, continue to increase through the dose range that was tested. Now, if we had run the Johns Hopkins study more or less the same, but without the psilocybin, based on what we saw on the previous Cochrane slide, with the same number of participants, here is what we might have expected. 15 would have gone into those studies, and the initial cessation rate would have been 9. After 6 months, 1 or 2 would have relapsed. And after 12 months, another 4 would have relapsed. Now, these are the theoretical figures based off of the Cochrane slide that I shared. In the Johns Hopkins study, by contrast, the initial quit success was 11 of the 15. And after 6 months, one of the relapsers had re-quit. And after 12 months, another 10 were still quit for a total quit success of 67 or 66.7%. That's pretty astounding. That's pretty astounding as well when you compare it to the 27% that we would expect from our current gold standard treatment. As we've discussed already, I'm going to go ahead here. As we discussed already, there may be direct pharmacological or neurological effects of psilocybin that serve to treat addiction directly. However, even if that turns out to not be the case, those effects will be consciously understood subjectively by the patient in a variety of different ways. Listed on this slide are the effects the patients themselves listed as important to their success. If we think of different levels of analysis with pharmacologic and neurological layers acting as the bases, and then moving toward the cognitive level, and then moving on to higher order psychological concepts like self-efficacy, and from there to the mystical or spiritual level, this list seems to imply dominance for the cognitive and psychological levels of analysis as being the most critical for recovery. Although it is hard to know to what extent higher order psychological concepts are mediated by the mystical experience and vice versa. The Hopkins team did find a correlation between the intensity of the mystical experience and the chance of tobacco recovery, a finding which corroborates similar findings in other psychedelic studies on substance use disorders, and which is also aligned with the broader literature on the role of spirituality in recovery. In any case, anyone who has worked with patients on an SUD will see several familiar concepts listed here on this slide that were important in the psychedelic-assisted recovery of the patients in the study. Now, of course, this was only a pilot study, just to test the waters a bit. So we should expect some limitations here. The study was small, only 15 people. It was disproportionately male, 75%, and disproportionately white, 93%. It was a single arm trial. Everyone received psilocybin, so there's no comparison group. It was an open label study, meaning that not only did all the participants receive psilocybin, they all knew they did, and so did all the researchers. So there was no blinding. So on the client side, we may have an outsized placebo effect. And on the researcher side, the possibility of enthusiasm may play a part. Although, at least on that side, the measurables of importance here are hard to misinterpret regardless of the rosiness of the lens in which they're viewed. Either the client quit smoking or they didn't. Still, it's a limitation worth noting. And I've already mentioned the overall health of the patient set. In another study, Johnson and team compared psilocybin to the nicotine patch. Once again, these participants were not blinded to their intervention, and so that same limitation applies. In this study, both arms received the 13-week CBT course. At 6 months, the continuous abstinence rates were 40.2% and 10% for psilocybin and the patch, respectively. These are still really astounding results, right? Although, to be fair, it's still no matter what, it's quite impressive compared to our non-psychedelic expectations. Now, this study is not yet published, but these results are located at the National Institute of Allergy and Infectious Diseases Data Ecosystem website. Johnson's team has another study ongoing, and this study is going to be a randomized controlled trial comparing psilocybin to a placebo, niacin. Multiple sites are still actively recruiting as of last month. One of the primary concerns surrounding psilocybin-assisted therapy is its legal status. Psilocybin is currently classified as a Schedule I substance under the United States Controlled Substances Act. This designation means it is considered to have a high potential for abuse, no currently accepted medical use, and a lack of accepted safety for use under medical supervision. This classification presents significant barriers to both research and clinical implementation. Because of its Schedule I status, researchers must go through lengthy and complex regulatory processes to obtain approval for studies involving psilocybin. Institutions must meet strict requirements for storage handling and oversight, which limits the number of researchers able or willing to conduct this work. Clinicians, even those trained and licensed in psychedelic-assisted therapy in research settings, cannot prescribe psilocybin outside of a clinical trial. Critics of the Schedule I classification argue that it's outdated, especially in light of accumulating evidence of psilocybin's therapeutic potential and relatively low risk of misuse in clinical contexts. Efforts to reclassify psilocybin are ongoing. Now, Although psilocybin remains a Schedule I substance at the federal level in the US, its legal landscape is beginning to shift. A number of cities, including Denver, Oakland, and Seattle, have decriminalized psilocybin possession, and Oregon and Colorado have both launched statewide programs allowing supervised psilocybin services. However, even in jurisdictions where psilocybin is decriminalized or legally available in clinical settings, its continued federal Schedule I classification creates legal ambiguity. Healthcare providers may be hesitant to engage with psilocybin-assisted therapy for fear of professional risk, unclear guidelines, or liability issues. And patients, too, may feel uncertain or wary about pursuing treatment that is not federally recognized and carries a social stigma, if not the threat of actual criminal prosecution. This tension between local reforms and federal law can create practical and psychological barriers to treatment, potentially slowing down the adoption of a promising intervention, even in places where it's technically legal. Cost is another important concern with psilocybin-assisted therapy. Because it involves multiple components, the preparatory sessions, the supervised dosing sessions, and the follow-up integration sessions all previously mentioned, the overall treatment can be extremely time-intensive and therefore very expensive. Currently, psilocybin therapy is not covered by most insurance plans, making out-of-pocket costs a significant barrier for many. Additionally, the need for specially trained therapists and controlled clinical environments just adds to the cost. These financial factors may limit access to the therapy, especially for underserved and systematically marginalized or minoritized populations, and could slow broader adoption, even as clinical evidence of its effectiveness grows. Psilocybin is generally considered to have a favorable safety profile, especially compared to many other psychoactive substances. Acute risks involve transient psychological distress, such as anxiety, panic, paranoia, and confusion during the psychedelic experience. Often these are grouped together and called a bad trip. Serious adverse events like psychosis or lasting psychological harm are extremely rare, especially when administered in controlled, supervised clinical settings with proper screening. Long-term negative outcomes appear minimal. Studies have not shown evidence of persistent cognitive deficits or addiction potential. To mitigate risks, careful patient screening, excluding those with personal or family history of psychotic disorders, for example, creating a supportive environment, and having trained facilitators present during the session are all key strategies to prevent long-term difficulties. Psilocybin's primary action on serotonin receptors raises potential concerns about interactions with other serotonergic medications, especially selective serotonin reuptake inhibitors, SSRIs, or monoamine oxidase inhibitors, MAOIs. Co-administration can theoretically increase the risk of serotonin syndrome, although, again, reported cases are rare here. SSRIs may also, and maybe more importantly, blunt the psychedelic experience, possibly reducing therapeutic efficacy and causing a sense of disappointment. Other medications affecting blood pressure or heart rate may require monitoring due to psilocybin's mild cardiovascular effects. There are a variety of ethical reforms. I listed our ethical concerns here. Informed consent and expectation. Because psilocybin induces profound altered states of consciousness, it's essential that patients fully understand the nature of the experience, its potential risks, and uncertainties regarding outcomes. Clear, compassionate communication helps ensure truly informed consent. The psychedelic state may also increase suggestibility, raising concerns about undue influence from therapists or group settings. Ethical practice demands maintaining boundaries, avoiding coercion, and respecting patient autonomy throughout the experience. Psychedelic use has deep spiritual and cultural roots in many indigenous communities as well. Appropriating these substances without acknowledgement or respect can raise ethical issues around cultural sensitivity and equity. And on equity, ensuring equitable access to psilocybin therapy is critical, as high costs and limited availability could widen currently existing health disparities. Ethical frameworks should address inclusion of underserved populations. And long-term follow-up. Ethical care includes providing adequate support post-treatment to integrate experiences and monitor for delayed psychological effects, ensuring patient well-being beyond the therapy session itself. And I'll also just say that there's also, if people are thinking about moving into this space from a clinical standpoint, there's still a lot we really don't know. I just listed a few questions that just came to mind. I could probably list 9 more of these slides, but we really don't know what prolonged or chronic use of these substances looks like in the clinical setting. We don't know about how it works in different populations. We don't know how different therapeutic setting pathways, including recreational use, may change therapeutic outcomes. In any case, um, we have reviewed a lot of material here. This is a little summary slide of everything that we talked about. And I'm just going to actually pause there because I want to leave at least a few minutes to see if there's any questions. Here are the citations, again, available. The list is available upon request. And I see that there are some questions in the chat. I'll just go through these here. Jamie O'Hara's asks, what information do we know about the negative impact these treatments might have on mental health and SUD treatment? Is there a way to know what characteristics that may lead to negative outcomes? Think, for example, about anxiety in someone who's struggling to quit using nicotine due to their anxiety. Yeah, so it's a great question, and we really do need to make sure that we are screening appropriately. There are some studies that psilocybin, we have sort of this confounding thing that goes on with psilocybin in particular. The main negative outcome that happens during the administration system or the administration session is increased anxiety. But this seems to be largely acute. It's sort of confined to the session itself. And then on the flip side of that, psilocybin's sort of long-term impact on mental health is that it overall reduces anxiety through a variety of potential mechanisms, a lot of cognitive reframing, granting of new perspectives that allow people to sort of relax. It also, de-emphasizes activity in the amygdala if you sort of want to take a sort of a neurological take on it. So, it's important in that case that the facilitator, the therapist really develops that therapeutic rapport, really develops that sense of trust with the client, so that if they experience heightened anxiety during administration, they trust that facilitator, is there to help them, keeps them safe, haven't accidentally slipped them some other chemical or something like that, whatever that paranoia or that anxiety looks like. In regard to other mental health conditions, there's just a general sort of broad prohibition against using these substances on individuals with psychotic tendencies. So that is psychosis itself, or any of the sort of mental illnesses that have psychosis as an element of it. So bipolar disorder and the schizoaffective and schizophrenia disorders, sort of staying away from psychedelics with those individuals. But as always, I mean, you kind of, it's not for everybody necessarily. It's not a cure-all, and even in a clinical environment, not everybody comes out, with improvement. And in fact, in some of the MDMA studies, there were some people who did actually get worse during the psychedelic treatment. So that's one of those sort of unknown areas, is how can we better optimize? Are there certain personality traits that are associated with better outcomes? And we're just going to have to, we'll be learning that as we go in some degree. Anonymous attendee has said, super interesting research. Has there been any research showing that clients became addicted to psychedelics as a result of them, a result of using them to quit tobacco? Now, in the tobacco studies, I certainly don't know of anything among those 15 people, but in general, these don't create a physiological dependence in the way that we normally measure dependence. Certainly somebody, there is a sort of anecdotal risk of people chasing the mystical experience, sort of kind of using, you start using it just more and more recreationally. But generally speaking, no, we don't see people being addicted or certainly not showing signs of physiological dependence. And with the tobacco study in particular, I've not seen that outcome, no. Yeah, so Edwards asked the same thing. Is there an addiction potential for psychedelics? I can certainly share. There's a great article that walks through the addiction potential of all the psychedelics. They across psychedelics, there are various degrees of addiction potential, but generally speaking, the answer is no. The addiction potential is extremely low. I'm having to yes, Erica, we can get the PowerPoints to you. How long do the positive outcomes last based on what we know so far? Yeah, so with some of like the depression studies, some of those SUD studies, we're seeing lasting effects at the 6-month mark, and sometimes up to the year mark. We start to see some movement back toward pre-existing states around that time. But some of that is potentially due to the need for ongoing psychotherapy. And this might be a situation where we might learn that regular, like yearly boosters may be helpful. But yeah, generally speaking, these seem to be fairly long-lasting results, especially when it's augmented with actual psychotherapy. And I'm seeing that the chat. Okay, I think I answered all those. Let's go into the chat. We are at time, so I totally understand if people need to log off, but I'll go through these questions. Potential risks are, again, psychedelics, psilocybin in particular, has a really nice risk profile. The risks are extremely low. There's very, very few drug interactions because it works exclusively at that 5-HT2A site. So I mentioned that there's potential interactions with SSRIs. There are a lot of sort of, I don't know, there's an old adage about starting up a mining camp, and like everybody wants to pan for gold, but the guy who makes the most money long term is the guy who sells shovels and pickaxes. There's a whole industry kind of growing up around the burgeoning psychedelic practice, and that includes from the pharmacological angle, where they're doing a lot of the drug and drug interaction research, and some of that research is sort of in the field, building the plane as it's flying sort of research, just building off of anecdotes and looking for those psychological, or those physiological interactivities, the pharmacokinetics and the pharmacodynamics. But generally speaking, there's a slight cardiovascular effect that needs to be monitored, especially with individuals who maybe already have hypertension, especially if that is it's like not being managed well. But beyond that, it's mostly the mental health stuff, the set and setting stuff that you'd have to be concerned with. So if you have a general healthy person, I would say the risk is extremely low. So Delia's asked, after reviewing this data, can you elaborate on psychedelics replacing versus being added to the traditional nicotine cessation treatments? There's trade-offs on all these things, right? Varenigline's not for everybody, and for some of those people, NRT is the right way to go under current treatments. And we're hoping that when cytosine comes online, cytosine is there for people for whom NRT and bupropion and varenicline aren't, varenicline, bupropion, and NRT aren't appropriate. I don't think there's, with a problem as profound as nicotine and the amount of death and disability that it causes, until we have a miracle pill that is 100% effective, I don't see any reason why we should be thinking that anything should come along as a replacement, right? The time cost, the legal threat, the actual financial cost of psychedelics it's not going to be appropriate for everybody. It's just not. I don't know that it's scalable in a way that, say, nicotine replacement therapy is scalable. And so I just see it as one more tool that people can access, So it says, what is meant by psychological flexibility? It's the ability, it's a lot, oftentimes associated with the idea of openness from your Ocean personality test. It's the idea that somebody can move into surrender, is open to new experiences, and believes in change, believes that change is possible, and is sort of open to new ideas and new interpretations of old ideas. Sort of, it is more or less defined in the terminology there. It says, Jordan says, thank you for the informed and engaging presentation. DORS released a report, a unanimous decision by their federally recognized American tribes and indigenous communities to pause psilocybin regulation efforts. However, I'm not sure how this will be enforced. What do you think about this? You know what, Jordan, I'm going to have to look into that. I did not know that happened, but I'm very interested in it. Yeah, slides will be available. What is the lower strength provided per session? So Rita's asked, what is the lowest dose? And there will be no dispensaries for psychedelics in Colorado. And you can sort of do whatever dose you want. They have tiered requirements for how long that person has to stay at the healing center. And so at lower doses, it's going to be below 5 hours. At higher doses, it's above that. And then the maximum dose, I believe, I have to review this, is 40 milligrams. But we're also doing it slightly different. We're using in Colorado, it's actually a measure of psilocin and not psilocybin. It gets very wonky and silly. But yeah, the dose, you can go as low as you want, but then the dose will determine how long you have to stay at the healing center is the bottom line. There's no lowest dose. I know friends who are offering guided cessations with ketamine in Minnesota. Are ketamine and MDA scheduled? Ketamine and MDA MDMA has no classification. I mean, I'm sorry, I'll just say stick with ketamine. Ketamine can be used off-label for a variety of different things, and it is under that auspice that you can see sort of ketamine clinics where ketamine is being used to treat depression, PTSD, and some of these other mental health conditions. So yeah, it has because ketamine has an actual clear medical use, it gets a different schedule, and so it has that it's an actual anesthetic, and that is its approved use. Then it has a breakthrough status for some of these other things. All right, everybody's logging off. I think I got most of the questions answered. I appreciate everybody's time. Thank you so much for your attendance.